Hello and welcome everyone for tonight's EAO Just Ask. Tonight it's an amazing pleasure because we have one of my favorite topic and one of my favorite speaker here tonight. It's Professor Mario Roccuzzo. He's the top-notch expert when it comes to this topic. He is an international lecturer. He wrote many books. He has a private office in Torino, in Italy. He lectures at different universities, also in Ann Arbor, Michigan. And for me, he wrote the best paper available in dentistry, a 20-year follow-up of implants in periodontal patients. Mario, you are my role model and you were my wish candidate, and also on behalf of me, but also on behalf of the EAO board, welcome to tonight's Just Ask and a hello to Torino, Italy.
Thank you. Thank you very much for this nice introduction. I'm really thrilled. I'm very happy to share this time with you and with other friends from all over the world. So I'm ready.
You're totally right. There are many people logging in from all around the world. There are people coming in from Armenia, Tunisia, Uganda, Arabia, probably all the countries you lectured in already. And Mario, I heard we have to give a little bit speed because there's a thunderstorm coming up in Torino, and we hold the thumbs up that you're gonna make it. So let's get going. And as you know, it is a little bit the tradition of this Just Ask that I look for a case which fits to you. And actually today I did a control of my patients in a periodontal maintenance. And I thought, I have Mario Roccuzzo with me. Should I show him a case where I placed implants in a perio patient? What do you think? Would he say? Would he do the thumb up? Would he do the thumb down? So Mario, this is what I did some 5 years ago. It was a severe periodontal case. I, of course, did some periodontal treatment, pre-treatment, oral hygiene instruction, supportive periodontal therapy. I did place 2 implants, hybrid type implants, high connection. I did soft tissue management, bone management. I splinted these 2 crowns. We had actually a Just Ask on this if anyone is interested in this. And this is 5 years down the road. Mario, what would you say? What would you do different? I mean, you are the expert in that area. Just give me your 2 sentences on that.
Well, probably in this specific case, I would have done the same. But the important question is, in order to understand if it's right or wrong, you should ask yourself, what kind of dentist are you? Because if you are a dentist who is mechanically oriented, the dentist who likes primary stability, who believes that implants perform better than teeth, they value immediate loading, and the reconstruction, the prosthetic reconstruction compensate for implant malposition. And sometimes they even remove bone. Well, that's one story. If you are periodontally oriented, you believe in biology much more. You like implants, but they are not always better than teeth. They have a long-term vision. They value soft tissue integration. They value the importance of maintenance. And they know that perio patients are at higher risk no matter what. No matter how hard you try, they are. So the result is that this type of dentist try hard to save teeth. So there is, I understand, there is really a different starting point from the dentist. The same case is treated in a different way because of that. So the question now is, when we have a patient like this, which are the risks and the benefits for implants in PCP, in periodontally compromised patients? Because oftentimes we see presentation when they show a case like this and they tell us that it's hopeless dentition. But do we really need to remove all teeth in order to reduce the germs, the pathogens? And we have several studies, and I don't want to spend much time in showing studies, but I just want to scroll them down, that insist on the fact that even if you remove all teeth and you do nothing and you wait, you cannot get rid of the pathogens at all. Pathogens survive even in absence of pockets. And this is a very important message because you cannot remove pathogens by extracting teeth. You can reduce them, This is an interesting study when they analyze the types of germs at baseline, at 4 months, at 8 months. And once again, the mean proportions of pathogenic and non-pathogenic species didn't change. Not only on implants, but even a denture. If you collect the germs before a denture and after a denture, you see there is a significant increase in the red complex bacteria. And we go quickly, but again, there is enough evidence to show that even a complete denture can cause a considerable increase of pathogenic bacteria. So the problem, the starting point is we cannot get rid completely of the bacteria. And you keeping this in mind, so you don't rush the extraction of teeth in order to be on the safe side. So if you have a case like this, you try to keep all the teeth which are okay, and you remove the implants which are real, and you remove the teeth which are really hopeless. But so often, so many times, we see too many teeth extracted in the perception that they can be substituted by implants with an easier and better and more predictable long-term survival rate. Now, look at this case. I like this case very much because it's a perfect treatment. Look at the baseline and after 2 months, after 2 years. The patient did very well. My surgery was successful. So in a case like this, you expect everything working forever and ever. Now, after so many years, she comes back and she has a problem on one implant, a tissue level implant. And you see bleeding on probing, the pocket. So this is an initial preimplantitis, the initial complication. Why is that? Well, probably because, as I said before, we were not able to get rid of the bacteria. And in an area where the soft tissue is not perfect, where oral hygiene measures are not that effective. So we have to help the patient to keep it clean. The soft tissue modification, the phenotype modification is a necessary mean in order to allow her to brush more properly, more effectively, with no pain, no discomfort. But this is to show that we can never say we won after 2, 3, 5, 6, 10 years. Complications around implants in periodontally compromised patients can always occur. So going
Mario,
back to
I have a quick question to that case.
Yeah.
Do you think it is the quality of soft tissue which you change now, which also helps the immune system of the patient, or it's really a mechanical thing of improving oral hygiene in that case?
I think it's both. I think it's both. And what I really like is not a great, huge amount of keratinized tissue.
Right.
What I really like very much is a soft tissue seal
Right.
that protects the underneath structure. So going back to your patient, be happy that after 5 years, everything is stable. But don't say, I won the war, because complications can ever occur. No, I don't want to be negative. I mean, you did a good job, but be careful. 1 year from now, 2 years from now, tell your dental hygienist to look carefully because complications are always around the corner. And that's what I wanted to study in the paper you referred to. How often do we see complications? Because this is the main topic. If they come very, very seldom, who cares? If they come very, very frequently, we better pay attention. So my original study was I wanted to know for myself, not for the publication. I had many patients who were affected by periodontal disease and were treated with implants. And many years ago, we didn't have any numbers. So I said, how is going to be 10 years from now? And if you look at the survival rate of the patients who were healthy, it's pretty good. Patients affected with the moderate periodontitis, it's okay. But the huge difference is if you see patients affected by severe periodontitis. And these are patients who came regularly for 10 years. So even though we have done pretty much everything we could, the difference is there.
But
If
Mario, could you understand that, why it worked for 4 years and suddenly it break down? I mean,
Nope.
how can we understand that?
We don't. We see that the percentage of complications start to increase after 6-7 years in a statistical way.
Yeah.
So that's the reason why I'm telling you, good for you for 5 years, but let's see what happens in the next 5 years.
Mario, I'm sorry, I'm a little younger than you. What should I do?
keep working this way, and pay attention.
I will.
Because so many times we see papers that present a 1 year follow-up, 2 years follow-up. Who cares? There is no benefit in reading papers like this. And if you look at this chart, of the 37 patients who had moderate periodontitis, 26 came regularly, were perfect patients, and only one lost an implant. While of the 11 who did not come regularly, I mean, they came regularly, but not as regularly. Maybe they smoke, maybe they didn't have perfect plaque control. Almost half lost implants. So what happens after you place the implant is as important as what you do before and during implant placement. So if you see a patient like this, which of course is very, very difficult, at high risk, first of all, don't try to remove all teeth. Try to keep as many teeth as possible. And then with time, let's see how it goes. He may lose some teeth, as in this specific case. He lost one tooth for fracture, one tooth for resorption. But the canine, which was really in terrible shape in 1998, is still there. So the message is the implants can help our teeth in periodontally compromised patients. That's the message number one.
Mario, going back to that case, because we have also listeners be a little not so experienced. What would be the main disadvantage? Because I would probably say 90% of all implant surgeons would say take out the teeth and place implants all on 4 or whatever. What is, you want to state that again, because I think it's very important for everyone. What is the major importance or advantage of keeping at least some teeth in the upper or lower jaw when placing implants?
The numbers tell us that in long term, after 15, 20 years, the number of complications of periodontally compromised teeth is not as high as implants. So the truth is that if you do things properly, you have higher chances of periimplantitis than periodontitis. And if you treat the tooth, there are always time to place an implant later on.
Right. Good point.
So don't rush the extraction of teeth. And I'm saying this particularly to young dentists. If there are people who are young listening to us and they want to be dentists for many years to come, have a long-term vision, because 20 years from now, they will still be in practice and they will be happy to see those cases. If they extract all teeth and they do all on 4 and 1 or 2 implants go balloony, the patient is going to be in a really bad shape.
What do you answer to people saying, I mean, if you do this in elderly patient, you will see root decay, root caries on these kind of teeth. Is that anything you see in your office in elderly patients when saving these teeth?
Sure. And you have to be careful. But again, sometimes you see those hole on 4, which requires manual dexterity to clean in a very difficult way. When people get older, they have difficulties in cleaning. And sometimes it's much easier to clean a tooth, even if it's not in a perfect shape, even though it's not as beautiful as you want to show on a screen. But it's the tooth that the nature gave to him or to her. And let's try to keep them.
Very good point, Mario. Thank you for that.
And also, this is the second part of the study where we did with the new surface. You see that in healthy patients, the survival rate at 10 years is 100%. And in the other groups, is still 97, 96. But look at the number of bone loss greater than 3 millimeters, which is basically periimplantitis. If the patient is healthy, is 0. But if the patient is affected by severe periodontitis, is over 10%. In a patient who is under control. So even though I did everything I could, even if the patient is a good patient, nevertheless, complications are always around the corner.
Yeah.
So if you have healthy patients, the chances of complication is extremely low. But if you have periodontally compromised patients, you can have excellent values of long-term survival rate, but complications can be there always, and you have to continue to keep an eye on them. Of course, the starting point is when we should place implants in periodontally compromised patients. And the answer, of course, is not before perio is done properly. Sometimes in these days, people are happy about immediacy, about fast treatment, just like, they promise the faster, the better. But in a patient like this, it takes a lot of time, energy, effort to change his lifestyle from left to right. In this specific case, were 6 months. Well, I don't believe in miracles in these cases. You have to take your time. And if you promise that they can have successful results in 24 hours, in a week, in a day, or whatever, you're just not telling the truth. Now, on the other hand, the absolute mistake is to wait and see, like this specific patient. She has gone regularly to visit a dentist for like 10 years, and the only thing she did was a scaling root planing or cleaning. And she kept losing attachment year after year. Now, in a case like this, you have to place implants, but again, the right procedure is to try to save as many teeth as possible, particularly teeth which do not have furcations. Furcations are still difficult to treat even in 2025, but single root teeth can be quite easily treated. And again, you see the timeline, 2007, 2008, 2009. And you see it took a while before we placed the implant, but that's the way to do it. And when we place the implants in periodontally compromised patients, we prefer tissue-level implants or hybrid
Mario,
implants.
can we go back to this initial thing also to make it a little bit more concrete? I find it sometimes difficult, and probably this also occurs to you. When is the cut-off point when the active periodontal treatment is not finished? I mean, is a 5 millimeter pocket with a little bit of bleeding, is that allowed? Or 2 5 millimeters pockets? Let's make it very clear, because I always find it a little unfair in this treatment, guys. No pockets, zero bleeding. Let's be honest, this doesn't happen in the office, right?
Yes. And in fact, you have to use your good common sense, because if you read the papers, you will never be able to treat the majority of patients.
Right. That's what I find too.
Yeah, right. On the other hand, this is not a reason not to take in consideration. For example, this specific patient, look at this. After beautiful treatment, she had 2 implants. And after so many years, she had an abscess in the upper left quadrant. And if we collected the bacteria, we see that we have all the bad guys there. When 3 years after initial treatment. So the truth is that you can never say in perio, it's over, it's done, I'm done, it's completely finished. So the trick is, when do we need to treat patients? When can we start to place implants? Particularly when patient is absolutely committed to take good plaque control. Because we cannot have full control of the bacteria, and we can always have infection, but if we do things properly, we can have good results. And this is the situation after 4 years, after 7 years, after 10 years. Is it over? No. Can I say it's done? No. Just like diabetes, just like high blood pressure, just like all the chronic disease, you can never, quote, solve a problem 100%. But if you look at the lady 16 years afterwards, she has kept all the incisors and remember how bad they were. She is happy. She can clean properly. She has had no inflammation. So clinically speaking, it's a success. But the number of times she comes in a year is still related to the risk. And in this specific case, she comes 3 times a year. Now, again, look at this case. Implants should be placed only after assurance of patient good motivation and excellent compliance. Not decent, excellent compliance. So this is a lady, 20 years ago, she's a nurse. She has perio disease. The only thing she asked me is not to have it removable. And again, how many implants could be placed here instead of the teeth, the anterior teeth, if do all on 4? But she didn't want to do that. And we went for a staged approach. You see here, a few implants are still in position, and still you can see there are a few pockets. Here, there is a furcation here, so it's not perfect. But in the meantime, she can survive, she can chew, she can eat, she can talk, she can walk around. And we trust her because she's doing very well. And when we place implants in periodontal compromised patients, again, we don't try to be brave. We don't go for immediacy, even though I could, because if I go for immediacy, maybe the implant is not perfectly placed. Maybe it's too deep. Maybe there is an angulation. Look, if we do ridge preservation, how nice it is to place an implant here, how easy it is to place the implant in the middle of the crest. And implants here, again, help the teeth. We're able to save the teeth, but we have implants that help our teeth. And now, after so many years, after all we have done, after all the successful story, we have one side with a deep pocket. Why is that? Because we didn't get rid of bacteria. It's not my fault. We treat the pocket, and look at the situation. It's now much better. She comes regularly, 2-3 times a year, and now the pocket is closed. But if we look carefully, we are happy with the result. We can be happy, but if we look carefully, we now have a problem on an implant. Is that severe? No, it's an early periimplantitis or severe mucositis. So now, after so many years, we have to treat it. There are several ways to treat mucositis. The idea is always to remove the infection. So we have had a patient with an infection on a tooth first, and a few years an infection on an implant later. We were then forced to open a mini flap just to have access to the pocket, pre-op, 1 year post-op. And this is the situation, and this is how it was. And now we have another pocket. Perio never ends, never. The pocket, we have now a flapless surgery, a flapless application of amelogenin, which is something we do in recurrent pockets. Again, 1 year post-op, again solved, much better. We see here the difference between 2005 and 2023, 18 years of post-op. Is it over? No. Sometimes, somewhere, we know she will have a complication. But if we keep an eye on her, the complication will be small.
Mario, can I ask one more question? It's so interesting.
Sure.
Sorry for interrupting you so many times.
Okay.
And
I'm
congratulations to these cases. Could we nail it down a little bit to the better the oral hygiene of a patient is, the more you would accept a questionable tooth, like a furcation grade 2, a residual pocket? Is that true? The less the oral hygiene is, the more strict you would be with extraction of this tooth. I
agree. You made the point.
Okay. So so the message also for the young guys is I could leave a molar with a furcation grade 2 and place an implant if there is a perfect plaque control and the patient has a very strict regular maintenance, right? And then make your decision based on good common sense, but don't don't think that the implant is going to be easier in the long run. Right. The successful of implant is based on the fact that the short term, they work very well. I mean, if you lose an implant after a year, it's an exception. Right. But the number of complications increases with time. So the younger you are as a dentist,
the more you should concentrate on keeping teeth.
Gotcha.
And look at this table on the 20-year results.
Unfortunately, I'm medium age, but anyway, that was a joke.
It's okay. It's okay. You're still young.
Okay, thanks.
After 20 years, if the patients were healthy, in 33% of the cases, we had to do antibiotics and or surgery. If patients were severe periodontitis, in 61% of the patients, we had to do antibiotics and or surgery. Six out of 10 cases in 20 years, which means that every time I place an implant in a periodontal compromised patients, I know that 6, 7 times out of 10, I will do something else in the future. So it's a different attitude. If you place the implant thinking it's over, it's one story. If you think, oh, I placed the implant, but sooner or later I will have to treat them again, it's a different perspective. So the idea of strategic tooth extraction is a bad idea. And periodontally compromised patients may need additional treatment of biological complications in a high percentage of cases, no matter what.
But still, Mario, coming back to, sorry for interrupting you, coming back to a patient with a bad oral hygiene and a bad maintenance and a severe perio, then it is probably also not a good candidate for dental implants and tooth extraction, right? So what should I do with him?
Well, you should work in trying to improve patients' health, no matter what. Right. That's our first mission. We are supposed to save teeth. We are supposed to help patients to improve their general situation. Now, sometimes we can be successfully 100%, sometimes not, but that's our mission.
Gotcha.
Now, there is another important point, which is implants near periodontal compromised patients. How should we place them? Because this is, for example, an implant which is not properly placed because, as you can see, is too deep. So sooner or later, this is going to become probably a complication, a severe complication. There are a few studies that confirm the fact that the deeper is the probing, the higher is the percentage of bleeding. And as periodontists, as dentists, we don't like bleeding. So we should place the implant as shallow as possible, as deep as necessary. Here you see 2 slides in the same patient. Okay, you see here, it's a shallow pocket, no inflammation. Here is a deep pocket, inflammation. Here are 2 sites with the deep position of the implant, a little bit of inflammation. The third implant, which is shallow, no inflammation. And it's normal. In perio, we don't want pockets. Why should we accept pockets around implants? So when we place an implant in a periodontal compromised patient, as in this case, we should think, how deep should I place my implant? If the implant should be placed shallow, I do everything I can in order to have a minimum depth around the implant. As in this specific case, I try to promote perio regeneration on the adjacent teeth so that the implant is not too deep. The pocket is shallow. There is no bleeding, no inflammation. And we have, again, a beautiful example of a tooth with minimal attachment, but still there. And how long it will last, I don't know, but we will keep it as long as possible. And you see that it even improves with time. And the implant is going to help the tooth, and the tooth is there. Now, this is pushing the envelope a little bit too much, maybe, but I just want to show the fact that if you place the implant without thinking about perio, you place the implant deep into the bone. Think about the pocket depth, mesial and distal to the implant. So where should we place the implant? As I mentioned before, as shallow as possible, as deep as necessary, which means we have to promote regeneration, periodontal regeneration on the adjacent teeth. And if you do things properly, you can be successful again for many years, after decades. This is, again, another case which is almost 20 years follow-up. Now, speaking about perio, if you have furcations, don't place
Mario,
an implant.
can I stay with the implant for a second, because I think this is I think one of the most important topics.
Okay.
And I am to 100% on your side. I mean, you saw my case. I also think it is good to place it as shallow, as sort of supracrestal as possible. However, we see a trend which is going in a complete opposite direction, which means place the implant as deep as possible and then use a meso structure or whatever. And the punchline of all of these people's is they want to make sure that the rough shoulder is in the bone. Because we have data that the rough shoulder is the sort of the starting point if it exposed for periimplantitis. That is a valid point, I think. I mean, I also sometimes have the feeling that don't place it too deep, but then I think, oh, but then I have the risk maybe the rough shoulder is exposed. What can you give me as an information or all the other people? I mean, how can I make sure it's not too deep, but at the same time, I don't have an exposed rough shoulder or rough surface?
The idea is that you have to create ideal conditions around the shoulder. Look at this case. For example, in this specific case, if I wanted to place the implant as shallow as possible in one step, it would be too risky. So what do? I treat the furcations, I enlarge the crest, I create more volume, and when I place the implant again, it's a different story.
Right.
So one of the problems is that people try to do things too quickly. Here in this specific case, it was done in two steps. First, I create ideal conditions, and then I place the implant. And if I place the implant, I don't see many chances the rough shoulder will be out in the oral cavity.
Right.
But again, look at it. This is even more significant. Look at the area in the premolar. Now, many dentists would extract the tooth. I try to keep it and do ortho treatment after perio treatment, okay? So we were able to obtain some regeneration. We were able to reduce the pocket, but still there is something left. Now, the implant is placed here. The rough surface is outside, but what do I want to do? Create regeneration, bone regeneration, vertical augmentation. Of course, this is difficult. I don't suggest anyone to start with a case like this. But from the biological point of view,
right,
think perio. So if I have an implant near a periodontal compromised patient, either I treat the site first and then I place the implant later, which is safer. Or if you are with many years of experience like I am, I graft, I put an additional soft tissue graft, suture, and this is it. And we are happy.
Perfect, Mario. Now, what would you tell people? I mean, now you're an experienced surgeon, but if I am a beginner, go back to that case, and I am rather on the safe side and place the rough shoulder on the most apical point which you have, which is obviously mesially. What would you tell me? I mean, now I sink it in until I reach the shoulder on the canine. Then I use a meso structure in order to do sort of a hybrid type, hybrid or implant. You got it, like a tissue level. And then I do tissue level reconstruction. You think this is fine, or implant is also then too deep?
It's okay, but what about the pocket distal to the tooth?
Huge problem.
So you are having an implant, which may be properly placed and properly restored, near a deep pocket. I don't like it. I mean, sometimes you have to accept it, but it's a problem. Periimplantitis is, of course, more probable if you are close to a pocket than if you are in a healthy site. So,
but if I understood you correctly, the worst you could do is now place it subcrestal and restore it sort of subcrestally from bone level, right?
Yes, that's the high risk, because if you probe, it probes a lot.
Got it.
If you probe a lot, it bleeds. If it bleeds, it's inflammation. If you have inflammation, you have mucositis. If you have mucositis, you're going to have periimplantitis.
Good point.
In 2 months, in 3, maybe it takes 6 years.
Yeah.
But in 6 years, it will be there.
Yeah. Got it.
Now, you were asking me about soft tissues, and let me show you one study which is under review now, because you probably remember that we published a few years ago There's 10-year results where we demonstrated implants that are not surrounded by KT are more prone to plaque accumulation,
Right.
even in patients coming for maintenance. So we wanted to see 20 years afterwards, how many of these implants which are with keratinized mucosa or received a free gingival graft with mucositis periimplantitis. This is brand new. Look at this. If you have an implant surrounded by keratinized mucosa, either originally or grafted, the percentage of periimplantitis is 4%. If you have an implant which is surrounded by alveolar mucosa, after 20 years, the periimplantitis is 25%. Now, again, it doesn't mean that all implants which have keratinized mucosa do not have periimplantitis and the other way around. But these numbers are significant.
But Mario, I guess this is the very first study showing that what we always feel as clinicians.
In fact, it's under review these days. So
congratulations.
Hopefully we'll publish it soon. And if we associate periimplantitis and perimucositis, again, alveolar mucosa 50-60%, keratinized mucosa 27%, half of it. Which means that the absence of keratinized mucosa in the posterior mandible is associated with a high risk of long-term biological complications, which means that the periodontally compromised patients, we pay more attention to the quality of the keratinized tissue. To finish, because time is running, let me show you one extreme case where a patient comes for perio treatment and implant placement. First of all, you see that before we talk about implant placement or extraction of teeth, we try to improve his oral hygiene, which we did. And now we see that the defect is huge, but we nowadays have ways to create new periodontal ligament, new cementum, new bone, and we can place the implant in a proper way. This to the extreme. This is, I would say, the end of the story after you devote yourself in perio. But the idea is to promote regeneration, periodontal regeneration, and to create enough volume for the bone, for the implant, enough volume of bone for the implant. We place the implant into the bone, we add a connective tissue graft, and you see the difference between pre-op and post-op. And we can be very happy. So, in other words, implants in perio patients, yes, if you have a missing tooth, or if you have really a tooth which cannot be saved, sure. But don't think it will make easier to maintain an implant long-term. In other words, try to keep teeth today. There is always time for an implant tomorrow. And if you place implants in periodontal compromised patients, never implants before perio treatment. I think we have enough evidence to prefer tissue-level implants. These implants should be placed as shallow as possible, as deep as necessary. Don't underestimate the importance of keratinized tissue. And always, always keep in mind, you have to check patients frequently and carefully, because complications can be always around the corner. And with this, I thank you for your kind attention.
Mario, that was amazing. I congratulate you to your lecture. Everyone is also applauding you here in the chat. That was amazing. I learned so much, and I hope that a lot of the people took a lot of home what you alluded to. Thank you very much. It was amazing. We have still some questions, and I would actually tell a lot of people come to our Congress in Monaco. Mario Roccuzzo is one of the speakers. So I just learned we still have an early bird rate, so you might get there quite cheap. So subscribe for the Congress. You will also meet Professor Roccuzzo. Mario, I have one more question. I want to come back to again this hybrid type implant or tissue level implant. So what do you think? If I am a bone level guy, which is probably for most of the people, a lot of commercials done for bone level implants, does the type of prosthetics play a role? So how should I construct my prosthetics, in particular in the transmucosal zone? I mean, if I'm doing it on a bone level design.
Well, I guess I'm not an expert, so from what I understand, the idea is to create an emergent profile. So we'll try to reduce the plaque accumulation, no matter what it is. So the idea is, biologically speaking, is to have shallow pockets and sites which are easy to clean. So when a dentist makes a reconstruction, he should keep in mind, number one, is this easy to clean? Because that's very important. And is the profile easy to clean? And that's probably the most important thing.
Gotcha.
I probably there are differences in materials,
yeah,
but I'm not an expert on that, so I prefer not to say anything about it.
Yeah. There are questions from people in the chat, and I thought it's an interesting question. What about smoking? We hear different opinions about smoking. Smoking, of course, is a risk factor for perio, but is it a risk factor also for periimplantitis? And does it take you away from placing implants in these patients?
Okay, I take smoking as a serious factor at the time of the first visit. The patient that comes on the first visit, he always wants to know how much does it cost, how long it's going to last, possibly complete. He talks a lot. Now, I try to avoid to answer to those questions because you know what? I tell the patient, the most important thing is that you can tell me if you are going to quit smoking or not. And I have a high percentage of people who quit smoking, high percentage, over 50%. I also published something for the Italian side of perio a few years ago. We also had one patient who increased smoking after initial visit, but this was because he divorced. So I remember the story. So it's not that I don't treat smokers, but I don't do sophisticated type of procedure in a smoker patient. For example, I don't mind to keep on hold him or her for several months before I decide if I can place or not an implant, depending on the circumstances. Sometimes the treatment is easy, there is no much regeneration needed. Sometimes it's very complicated. For example, all those patients you have seen in the last part of my presentation, which were difficult to treat, all of them are non-smoking. And I don't do this because I'm a good guy. I just do because I'm egoistic. I don't want to put myself in trouble.
I got it. Mario, there's a question to when to extract teeth and when to keep teeth. I think you alluded to that, but probably the question goes a little bit to the idea is what kind of teeth do you take out in terms of the periodontal treatment? And so which are really hopeless teeth which you take out before starting your perio treatment? Maybe this is a little bit the question we had.
The older I get, the less teeth I extract. That's rule number one. Second molars are probably the teeth, and third molars are the teeth I extract most of the time because they are more strategic. If the presence of a furcation, open furcation, it's not a good reason to extract the tooth. Nowadays, we know that. While compared to 20 years ago, I extracted many furcations, many teeth with furcations involved, open. But I really try to keep as many teeth as possible.
Got it.
Because again, it's not because I'm a good guy. Because again, I really think that I will save my life.
Yeah. Mario, there's another question on the emergence profile or emergence angel. I think we alluded to that. Pretty much, if you use tissue level implants, you do your reconstruction from tissue level, so the emergence is not your problem. You agree with me, or you want to add something to that?
No, if you do a bone level implant, the emergence profile should not be too wide.
Right.
The literature says that an angle of 40 degrees is maximum 30, 40 degrees. So if you do a bone level implant, keep the angle in mind.
And if you do tissue level, you don't have the problem.
You don't have the problem. So that's a problem.
Mario, one final question, and there are a lot of people. You can read the chat later. They applaud you. They say great lecture. They want to see you in Monaco, so it will
Yeah,
look good.
please come to Monaco.
There's one more question from my side. Also, people talk about soft tissue height, which seems to be a little bit a modern topic. Like we need a certain amount of soft tissue height. You pretty much said the opposite now. We need a shallow placed implant. So is that the opposite, or do you mean we need a certain type of soft tissue which is not too deep? You understand my point? So do we need soft tissue height or should it be shallow? So maybe make that point clear because now it
Yeah.
seems to be a little opposite.
No, I mean, when I say as shallow as possible, I don't mean zero. I mean 2 millimeters, which is the supracrestal tissue height. 2.5 millimeters is more than enough. And what's important is you need the tissue thickness and the soft tissue seal around the core of the implant.
Yeah.
So both things are necessary. If you have a very, very thin tissue, for example, in the mandible, sometimes we have very, very thin tissue, no keratinized mucosa. In those cases, I graft with a pharyngeal graft first, and then I place the implant. In this way, I have both the supracrestal tissue height and the tissue width.
Right. Mario, that was amazing. There's one more comment, and I think we can conclude with that. He said already in 73, Hirschfeld and Wassermann said that furcation involvement is not a reason for extraction. I think this is a good endpoint of our lecture this time. Mario, I thank you very much on behalf of the EAO and also the EAO board. Greetings from all around the world. The people, they loved your lecture. They applaud you. You are a role model in that area, placing implants in periodontally compromised patients. And today I want to change it a little bit, maintaining teeth in periodontally compromised patients, and if needed, place an implant. I think this is the better topic, right?
Thank you for the suggestion. Maybe I'll use it for my next presentation. Okay.
With this,
and I'll quote you.
Yes. With this, come to Monaco. There is an early bird rate, I think, in this week or next week. You'll also see Mario Roccuzzo. Mario, with this, I want to thank you again from everyone. Say hello to Torino. I think the thunderstorm, it didn't hit you. At least it looks like it.
Nope.
And we're happy to see you in Monaco or at any time. Thanks to all around the world. Ciao, ciao. Good night. See you next time.
Thank you. Thank you very much. Ciao.